Okay, so today we're going to continue our discussion on in the hematology section of first aid that we are currently doing. And specifically today we're going to find out how can we uh, understand iron studies. So what is the interpretation of iron studies? Basically, this table that is given in first aid, this table that is given in first aid. What is the importance of this table? What is the importance of this topic? This is what we need to understand. So first of all, you must know what iron studies are. Iron studies is basically it's a type of a blood report in which certain aspects of iron metabolism, iron accumulation, or ferritin levels, serum iron levels, transferrin saturation, basically certain variables related to the iron situation in the body that is discussed in iron studies specifically. So this is not done first line. Routinely, we do not do iron studies. Routinely, we do something known as the CBC, the complete blood profile, right? So the complete blood count, or you can also call it as CP sometimes, in which there is the complete profile of the blood. So CBC, if I can, I will try to write them properly if I can. So, so CBC or CP, right? So this is CBC and this is CP. So these are the two routine blood tests that are done whenever a patient walks into a clinic, and if there is certain acute problem with the patient, or if the physician wants to get an idea of different components of blood, of hematology, then he orders a CBC and a CP. So last time we looked at the division of anemias, and we looked at this parameter known as the MCV. So it is important to understand that MCV is seen in CBC, which is a routine blood test. So I think you sort of get an idea that once a routine blood test is ordered, the physician looks at the MCV, the physician looks at the total hematocrit and the total RBC count. So all of these are present in the CBC. The CBC has hematocrit, the CBC has RBC count, and the CBC also has the MCV. The CBC also has the MC. Let's see. So CBC has different components to it. These things are important to grasp in the beginning of an evaluation of a patient. So this is all covered by this routine test. Looking at these and certain other parameters as well, if I could find those parameters. Let's see if we could uh, find the CBC blood test online, so that it would be a bit easier for us to understand. So yeah, so these are main components of the CBC. So you can see that there is a WBC count, the RBC count, the hemoglobin, which is also an important aspect which I forgot to mention, hematocrit, MCV, MCH, and MCH, RTW, which is also another important component which I forgot to mention. So this is basically CBC. If I could, yeah. So this is the complete CBC, right? This part, not the chemistry part, this part, in which there is also the distribution of the WBCs that are present in the blood. So neutrophils, lymphocytes, monocytes, eosinophils. So just for the demonstration purposes, I just like to go back to this one. So this is a routine blood test. This is the first blood test that is ordered. This is going to give you a general picture. So you're going to look at the hemoglobin, concentrating specifically on the hematologic part. I'm going to explain. Of course, there are other differentials that you can also diagnose, or not diagnose, but differentials that you can concentrate on, that you can have in your mind, looking at this report, but I'm just going to concentrate on if the patient is coming with a hematologic problem. So, looking at the RBC count, the hemoglobin, the hematocrit, the MCV, sometimes the MCHC. This is particularly important in patients with thalassemia or hereditary spherocytosis because then this value is increased. In hereditary spherocytosis, the MCHC is increased. Why it is increased, I'll explain it in the subsequent lectures. But these components are generally looked at. Even the RDW is generally looked at to get a general picture of what the problem is in the patient. So once you look at a general picture, once you look at these values, you look at everything, then you can go towards narrowing down your differential. So then you can go towards narrowing down your differentials. And if you think that the patient is having any problem with any problem related to the anemias, then you can go towards the iron studies because this is going to provide you generally detail of iron in your body. So if I had to put it simply, I would say that this provides the detail of iron in your body. And as you can see, there are different conditions and there are different variables. And knowing and understanding how these variables connect or behave in these particular conditions, this is how you will get to your diagnosis particularly. This is important for your question. So this is very important because half of the hematology questions will have iron studies in them or they're just going to mention them somehow. So this is very important. But before looking at this, we should look at these two things right over here. What are these? So first, I'm going to read them from the book, and then we're going to look at the notes. So reticulocyte production index is also called corrected reticulocyte count, which is also known as Retic count in short form. Uh, so it is used to correct falsely elevated reticulocyte count in anemia, measures appropriate blood bone marrow response to anemic conditions, effective erythropoiesis, high RPI, which is greater than 3, indicates compensatory RBC production. Low RPI, which is lesser than 2, indicates inadequate response to correct anemia. It is calculated as the percent reticulocytes given in the question multiplied by the actual hematocrit divided by the normal hematocrit. So this will be given in the question. This you already know. This is 45% and divided by the maturation time, which is I think will also be given in the question, I suppose. So they don't really outright give you a question and ask you to calculate the reticulocyte production index. That's not what they ask you to do. Normally, what they do is they just give you a reticulocyte production index in the question, right? Or if they want to make the question a bit difficult or a bit tedious, what they will do is they will give you the uh, reticulocyte percentage, and then they might give you these values and ask you some other thing, some other concept for which you need to calculate this. So this is going to be one of the two steps to solve that question. So that is how the questions come. They're not just going to ask you to memorize the formula, but if you know the formula, then that is good. The basic concept you need to understand is that this is a corrected count. This is also a count, but this is a corrected count. What happens is when there is anemia, I've also explained in my previous lecture. So if there is less blood, so there is less number of RBCs. So obviously, when there is something less, the body is going to start to increase its production, right? So after increasing its production, what happens is that the production not only increases in volume but also in speed. So it also increases in volume, but it also increases in speed, right? So the RBCs are being produced more and they are being produced rapidly. So the problem over here is that when RBCs are being produced rapidly, then what happens is that, of course, there is going to be a decrease in the maturation time, in the maturation time of RBCs. So RBCs will get less time to mature. So if when RBCs get less time to mature, what happens is that more immature forms of the RBCs are getting released into the blood. One of which is the most prevalent immature form is the reticulocytes. There will be increased reticulocytes in the blood, right? So reticulocytes are always going to always going to be present when there is decreased RBCs. When there is basically an anemic situation in the body. But the problem is that this value is going to be uh, high in the beginning, right? So this value is always going to be high in the beginning. We don't know if the reticulocytes that are being produced are increasing in the blood, or the reticulocytes that have already been produced are there. So what happens is that there is increased reticulocytes, right? This much we have established. And there are also increased reticulocytes that are being newly produced and that are already present in the blood. So both of these components are present in the blood. How can we know that which percentage of the increased reticulocytes are the ones that are being newly produced? The reason we want to know this is because we want to understand that the whether the production of new reticulocytes is intact or not. So if the value of newly produced reticulocytes is normal, we can deduce that bone marrow is working. We can say that the bone marrow is golden. So the bone marrow is normal. We can say that the bone marrow is working. If this situation, if the newly produced reticulocytes are decreased in levels, this indicates that the bone marrow, I'm writing bone marrow as BM for short. So bone marrow is not normal, right? This shows that the bone marrow is not normal. There is some problem with the bone marrow because the bone marrow is not producing enough reticulocytes. Now, the reason why we need to know if the bone marrow is working or the bone marrow is not working is because we need to again narrow down our differentials. So, narrowing our differentials down is the ultimate end result of this whole process that we've done. So, let's read them for the notes. So, this corrects the reticulocyte count for anemia because if the hematocrit is low, the percentage of reticulocytes appears falsely high, right? This helps assess bone marrow response. So, if the value is greater than 3, bone marrow is responding appropriately. It's a compensatory erythropoiesis. So, either there is blood loss, there is hemolysis, but the bone marrow is fine. If the RPI is low, then the bone marrow is not producing enough, which means there is some problem in the bone marrow. Either there is iron deficiency or there is aplastic anemia. This is how you've narrowed down your differentials, right? The fact I just want to explain that they've written here like this, if the because if the hematocrit is low, the percentage of reticulocytes appears falsely high. This is exactly what I've explained it to you guys that when there is anemia, there is also hematocrit in the blood, which means that the hematocrit basically means the presence of the already prepared reticulocytes or the old, I should say, the old reticulocytes, right? The cells that are already present in the blood or the cells that have been already produced, the old reticulocytes plus old RBCs. So that is what hematocrit represents, old RBCs. In this example, the N indicates the newly produced, the P indicates the already prepared, the already present reticulocytes. So they've just signified P with hematocrit. That's what you need to know because I don't want you to get confused by the words. So hematocrit just shows that the reticulocytes are already present. So of course, if we take the whole value together, it's going to be much bigger. We need to understand that what is the value of the newly produced reticulocytes. That is more important, right? So this is the rationale for calculating the reticulocyte production index. So all of this information is going to be given in the question. Normal, you must know, is 45%. The present reticulocyte hematocrit would be given in the question. Reticulocyte percentage would be given in the question. Maturation time would be given in the question, and you're just going to solve it. So I could not write fractions here, so that is why I've done this. But this is basically just uh, an example. So I hope this is clear now. Moving on to Menzer index. Menzer index is used to differentiate between thalassemia and iron deficiency. Because by both of these specifically, because both of them are a part of microcytic anemia. If you could see that thalassemia is a part of microcytic anemia and iron deficiency is a part of microcytic anemia, and both of them are relatively more common than the other two. So the most common is iron deficiency. After that, I would say that thalassemia is more common. After iron deficiency, most common is I would say the most common is iron deficiency. So we need some criteria to differentiate between the more common causes of iron deficiency of macrocytic anemia. We need a method to differentiate between the two most common causes of macrocytic anemia, which are iron deficiency and thalassemia. So an index less than 13 suggests thalassemia, and the index more than 13 suggests iron deficiency anemia. I think that's simple. I need to remember. The index more less than 13 suggests thalassemia, more than 13 suggests iron deficiency anemia, and this is the formula. So MCV divided by the RBC count. So both of them you would know from the CBC report also, and it's also going to be mentioned in the question if they want you to. But this is basically more of a real life, it's more of a real life application in which you can look at the CBC report of the patient and understand that whether it is thalassemia or iron deficiency anemia. So that is why that is the application of Menzer index, right? I have an example, I think, written here. Um, yes. So it helps differentiate microcytic anemias, and we've studied all of it. This is the calculation. So you just need the MCV and the RBC count, and just divide both of them, and you get the answer, right? Now looking at the crux of the discussion, the interpretation of the iron studies, the most important part. This one. First of all, just keep in mind that these variables are given in the iron studies, which is the serum iron, the transferrin, the TIBC, ferritin, percent transferrin saturation. These are the uh, variables that are given in the iron studies. Okay. Serum iron is relatively easy to understand. It's the level of iron that is in the blood. Transferrin or TIBC is basically it's the iron binding capacity. So it's the total iron binding capacity or transferrin. So what transferrin is basically that it transports iron in the blood. Like it's written right over here. It transports iron in the blood. So iron is bound to transferrin. Transferrin is a protein. It binds iron and it transports iron into the blood. So TIBC is same as transferrin is because let's just say let's just say that this is a transferrin protein, right? So this is the transferrin protein, and this is an iron molecule, Fe plus 2. This is an iron molecule. This is a transferrin protein, right? So this molecule has to bind with this protein in order to travel in the blood, right? So this is a big protein. This is a big protein, and you might not think it is big because I've inadvertently drawn the iron molecule as big. So if I could draw a small one so that it would be easier to illustrate. So this is the iron molecule. Okay. So transferrin protein is bigger than the iron molecule. There can be multiple iron molecules or iron elements that can be present on the transferrin protein. There could be multiple iron molecules present on the transferrin protein. But let me ask you, if there is low iron in the body, what will you think is going to happen to the capacity, the carrying capacity of transferrin, one transferrin protein? What do you think is going to happen? If iron is low in the body, what do you think is going to happen to the carrying capacity? Of course, the carrying capacity is going to increase. There is going to be more empty space on the transferrin protein. There is going to be increased TIBC. So TIBC is basically the carrying capacity. TIBC is basically the carrying capacity. If there is less iron in the body, the TIBC is going to increase. If there is more iron in the body, of course, every individual carrying capacity of the transparent molecule is going to decrease. So these both will always be opposite to each other. So transferrin and TIBC is the same thing, essentially. Ferritin is the stored form of iron. So basically, ferritin signifies the iron stores of the body, how much iron is being stored in the body. Okay, and the percent transferrin saturation. The percent transferrin saturation is basically how much the transferrin molecule is saturated. So if iron is low, the percent transferrin saturation will also be low. So these both go in conjunction, because if there is less iron, there's going to be less percentage of the molecule that is saturated by iron. If iron is low, there's going to be increased carrying capacity of the transparent molecule. So these two are opposite, but these two are same, right? These two are the same. These two are opposite. So now that you know the basically you had a quick review of what these variables are, just need to put them under every situation. So if there is less iron in the body, which is iron deficiency, serum iron is going to be low, TIBC is going to be high, as I've explained. Ferritin is going to be low because less iron, less storage, right? And percent saturation is going to be low because less iron would lead to less percent saturated, as percent saturation of the transferrin molecule. Chronic disease. So anemia of chronic disease, what happens is that in anemia of chronic disease, you will look at the pathophysiology of it in a bit. We would revise it, but what happens is that there is enough uh, stored iron in the body. There is enough iron in the body, but it is not being released due to the release of some cytokines. It is not being released from its stored form. It's not being converted to the active form, so to say. So it is stored in the body, but it is not being released. So the serum iron levels will be low because it's just kept away in a basement, sort of thing, right? So TIBC is also going to be low because serum iron is low, so TIBC is going to be low. And in this situation, this these two go in conjunction, right? So these two are same in this situation. The reason they are same is because serum iron is low, the free form of iron is low, the active form of iron is low, but there is increased stored form, right? So stored form is also so the stored form. So if I could just tell you that the stored form comprises of two uh, basically levels. So one of them is stored in the transferrin molecule, bound to the transferrin molecule, and one of them is stored in the as a ferritin molecule. Right. So if the stored form is high, if ferritin is normal, if stored form is high, then what happens is that TIBC is going also is going to be low, right? Because the saturation is going to be normal. It's either going to be normal, it's either going to be low, but the saturation is going to be normal. So the carrying capacity is going to be less. Okay, carrying capacity is going to be less because stored form is high. More iron is also being stored on the transferrin molecule. The capacity is also going to be low. The saturation is going to be normal. Saturation becomes normal eventually. Saturation is not going to be high because it's not overloading the transferrin protein, but it's going to be normal. So when the saturation is normal, you obviously know that there are iron molecules being bound to transferrin protein, so the TIBC is going to be low. It's not going to have an increased capacity, but the serum iron is low. So this is sort of a problem in a chronic disease is that iron is normal in the body. It is stored. It may also be increased. It is bound to the transferrin molecule, but it is just not being released in the blood, right? And it's thus giving us anemic features. Hemochromatosis, on the other hand, starts by increased iron in the body, maybe by the use of increased iron supplements or any other way, or increased transfusions. There is increased iron in the body. So, increased iron in the body, increased serum iron, obviously would lead to decreased TIBC, and the transference saturation is also going to be increased a lot because it's sort of overloading the cell. Okay, and lastly, it's pregnancy OCP use, not really widely asked. It's not really high yield, but the situation over here is just normal changes. What it's just physiological changes. So OCP use increases the level of estrogen, right? It increases the level of estrogen in the body, and estrogen increases the production of proteins. So basically, what happens is that transferrin is increased in the body. There is more transferrin protein. So now there is, of course, there will be more carrying capacity. If there is more transferrin protein, so liver makes transferrin. Estrogen orders the liver to make more proteins. All proteins are increased. Thyroid binding globulin, steroid binding globulin, transferrin, everything is increased. Every protein is increased. So if there is more transferrin present in the body, even if the iron is normal, there is going to be an increased carrying capacity because there is more transferrin that more than that is needed. Normal level of iron is present, but there is more transferrin, so TIBC will be increased. Ferritin is going to be normal. Transferrin saturation is going to be decreased because percentage is calculated from total iron, right? For sorry, not total iron, from the total transferrin that is present in the body, right? So if TIBC is going to be increased, transferrin is going to be increased, there will be less number of transferrin proteins that are going to be saturated, normally saturated with iron. So of course this is going to decrease. So the main problem in this situation is the presence of more transferrin. So and I think you're smart enough to take it from there. So this is the interpretation of iron studies. It's a simplified version. And one thing that is written here is evolutionary reasoning. Pathogens use circulating iron to thrive, which means the serum iron. The body has adapted a system in which iron is stored within the cells of the body and prevents pathogens from acquiring circulating iron. So they've written this here is because chronic diseases are basically chronic inflammatory diseases, mostly chronic inflammatory diseases. So what happens is that the body thinks that because it is being attacked by inflammation, it thinks that it is being attacked by any pathogen or any problem is being inflammatory response is being generated. So what the body does is it removes the iron from the blood and it stores it in the ferritin and it prevents the release of iron just because body thinks that if the iron doesn't get released, then the problem is going to be solved, but this turns out to be a bigger problem in the future, right? Because the body cannot essentially differentiate between a pathogen attacking the body and any autoimmune disease attacking the body, any autoinflammatory disease attacking the body. So the body cannot differentiate between both of them. So this is the point that is written here. And I guess this is it for this section.